Toastmaster Club. Okay, the video will be recorded. So I would like to invite the representative from NDA Toastmaster just to give a small introduction about what is Toastmaster Club, because I'm pretty sure a lot of you guys don't know what is Toastmaster Club. We have in NDA as well. It's mainly for the youngsters to build your networking, your connection, and learn how to talk. It's really good. And can I have the representative from the Toastmaster Club to take the stage? Thank you so much, Doc.
All right. Okay. Hi, everyone. So I'd just like to share my screen for a bit. Okay, everyone can see my screen? Can see? Great. So hi, everyone. It's great to see so many of you all here today. So my name is Nicole. I'm the Vice President of Public Relations for MDA KL and Selangor Toastmasters Club. Thank you all for allowing me some time to introduce you guys to Toastmasters. So now I want to ask one question, and I hope you guys can help me by answering, by typing in the chat box, okay? So do you like to speak in front of a crowd? Now, if you like, type 1 in the chat box. If you don't like, type 2. So I want to see some response. Let me see. Hold on a bit. Let's see. Okay. So I see lots of 2 actually. 2. Wow. Only if I know what I'm talking about. Okay. All right. Okay. Thank you so much for your answers. All right. So if you press 2, it means that you don't like public speaking. And that is actually normal. In fact, you might ask, what does public speaking have to do with my work in dentistry? Well, my answer is a lot. Now, as dental students and dentists, actually, we can't run away from public speaking, even though we don't like it. Whether it's giving a speech for research presentation or answering questions asked by interviewers during a postgrad or hiring interviews, or trying to convince your patient to take up your treatment plan. Public speaking skills play an important role in all of this. So if you can see my slide now, let's see, look at this person. Is this you? You know, when you're giving an oral presentation, do you sweat and then you become so nervous that you forgot what you were supposed to say? Or when you're convincing your patient to take up your treatment, you feel that you might explain and explain, and sometimes the patient just can't be convinced. Or maybe the patient throws you a question suddenly, and then you're unprepared and you cannot think. So you say, and then the patient feels that, okay, maybe this dentist is not so confident. Okay, if any of these situations ever happen to you, you type 1. If it's never happened to you or you're really good at tackling it, you type 2. Just want to see some interaction from you guys. Okay, great. Oh, hello, Azra says 1. And I see, okay, a lot of people say 1. Hello. Okay, Narina says 1. Narina says 1. Okay, thank you so much. So for those who said 1, which means yes to any one of those, Toastmasters Club is the platform for you to join others who are having similar struggles. Now at Toastmasters Club, what we do is actually just give you a platform, a stage where you can practice your public speaking skills in front of an audience who are also learning just like you. And to ensure that you get better with every speech that you give, we have experienced members who will give you feedback after every speech. So I just want to introduce to you all the structure of our meeting and see how it will help you. So first, we have a session called Table Topic Session, which is actually an impromptu speech session which trains your quick thinking skills. So this will train you to answer all the questions thrown to you by maybe interviewers or patients. Next, we have the prepared speech session, When you go up, you give a speech, and this is where you build your confidence and communication skills so that you know how to tackle different types of patients with different approaches. And lastly, we have the evaluation session, like I mentioned. So an experienced member will be giving you feedback after your speech. Okay. So do you guys know how many Toastmasters clubs are there in the world? I want to give just an estimate. How many are there in the whole world? Okay, 1,000, 5,000. Okay, I'll give you a clue. A little higher than that. 500. Okay, I just tell you guys the answer. It's a bit hard to guess lah. Okay, 100,000, no lah. So it's about 16,000 clubs, and now it's getting more and more. I think it's about 16,800. So you have 16,800 clubs in over 143 countries. So that's actually a lot of people that you can connect with. All right. So after you join Toastmasters International, there's actually 11 pathways that you can choose from. So if you want to hone a particular skill, you can go for that pathway. For example, you want to improve your presentation skills. So we have something called presentation mastery. So if you want to be a great presenter, a great dentist, leader, an inspiring speaker someday, join us now at our meeting to find out more. So you can scan this to join our guest group, or you can follow us at our Instagram and Facebook page to learn more. Okay, so with that, I'd like to thank all of you for your time, and I'd like to pass the floor back to Dr. Vinesh. Thank you so much.
Thank you so much for the introduction for MDA Toastmasters. So everyone who are dentists around here, please do join the MDA Toastmasters. I would advise, because it's basically for youngsters. Most of them are youngsters, and you can try to join as guests first and see how you go. And I think they do give, if you get like best speaking, I think you get some gift and present, I think, right? If I'm mistaken.
Yes.
Yeah, so there's something you can, and it's good for networking, and you can meet a few of the senior doctors will be there also to help you. They're really good. So it's a good platform to start and move with your career as a dentist. And you guys can PM them directly. Either you use the a scan box, or you can just directly see them in their Facebook or Instagram. Just contact them. All right. All right. I can see Dr. Brian there. Hey, thanks, Dr. Brian. Dr. Brian from 3M is there. So today is Thursday, Batik Day. Yes. So so before we go to our main agenda, I just want to share a bit of something. Then we can go to our main agenda. All right. If everyone can see, just put a thumbs up. All right. Thank you. So thanks to our another sponsor. Thank you. We have two sponsors again. One of sponsor is MDA Toastmaster Club. So you guys should join them because they are sponsoring this, and they'll be sponsoring more in future also. And they've been doing a lot of other programs as well. So do join them, support them. And also another sponsor of ours is Restaurant. Okay. So they are giving some special promotion from 29 July, which is today, till 8th of August, 8 on. So they're giving like 150 ringgit off. So you can just directly contact them in their IG. Their IG is resto.ren. All right. And just use the promo code Dr. V 150, and their equipment is quite good. So do join, do use this. All right. The promo is there for more than a week, I think. And another thing I would like to share is about, normally I give this to the end, but I just finish it off now. All right. So this is basically our next webinar, okay, which is on 19th of August, all right, 9 p.m. to 10 p.m., research and publication for beginners. So we were able to get our speaker. Our speaker is, I call him Dr. Bud. Okay, he's actually a lecturer from IUM. He's actually an oral radiology specialist. So he's very active in presenting, publishing. So he wants to give something simple for you guys because it's quite important for the newer officers who have joined the services. So that's from my side. So I would like to go to the main event for today. Again, thank you for everyone for joining. Thank you for MD Toastmaster. Thank you, restaurant. Okay, today's is series 6, 2021. Okay, today's topic is biomimetic dentistry. What, why, and how. So we were able to get Dr. Kathleen Tan. All right, she's basically an associate dentist from Penang Dental Surgery. All right, so she graduated her BDS from MMMC. All right, and she is a certified biomimetic restorative dentist in Malaysia. So it's a very interesting topic. It's something very, I would say, is new in Malaysia. And we have Dr. Kathleen who have done this course with the professionals from overseas. And she's here to share what is it, how to go about it, and what we can expect. All right. So I would like to pass the floor to our main speaker today, Dr. Kathleen Tan. If you can.
Thank you, Vinesh. Hello, everybody. Hold on, let me just set up my screen. Vinesh, you need to you stop sharing first. Okay. All right. All good. Okay, can everyone see my screen? All good? All right. Okay, so thank you, Vinesh, for invite. And hi, everyone. It's, sorry, technical difficulty. You can see, right, my screen, full screen, right? All right. Okay. Okay. So yes, hi everyone. So this is very exciting for me. Firstly, I just have to say thanks for being here. I know that Lee Zijia is playing a super exciting badminton Olympics match. So I don't blame you if you're watching both at the same time, okay? So it's really a privilege to be speaking to dentists across Malaysia. We were saying that it would have been nice to meet everyone in person, but it's okay. We're too used to webinars now. I love that there are many that I met through Instagram who's here tonight. So it's still good meeting online, at least better than nothing. So Vinesh or Nicole, please feel free to stop me anytime if I'm too fast or too slow or too boring. Okay, that one I cannot help. Okay. All right. So my name is Caitlin. I'm currently working in private practice in Penang, and I'm working with my dad, who is the founder of the clinic. That's him in the bright purple tie. And my sister Nguyen joined us a couple of years ago as well. I have a sister Xiaowen in KL, who's also a dentist. So yes, it's a family of dentists. So in our clinic, we have a team of about 6 dentists and about 12 nurses. And some of them are here tonight. So hello, everyone. So these people make work very fun. So it's a joy going to work every day. Okay, so Vinesh asked me to share my dental journey and what BRD is all about. So from here on out, I'm just going to call BRD. I'm going to call Biomimetic Restorative Dentistry as BRD. Okay, it's a mouthful. All right, so my dental journey. So as I started private practice, it was where I developed confidence talking to patients, diagnosis and treatment planning. And looking back, it was good having a mentor who is my dad. He's here today too. Hi, Dad. But I remember back in the early days, I was like, is it a good thing or bad thing having a mentor? Because I remember at least back in the first few, like the first couple of years, I kept having to call back the patients to re-prep or retake impressions because my impression was bad or my prep was terrible. And every single time I'm like, why? Like, does everyone have this? Is it a good thing having a mentor? I don't know. But I'm glad he did that to me. I guess Asian parenting is like tough love, right? So because of him, I've embodied the phrase learn to fail or fail to learn. So to me now, it's okay to make mistakes because failure is not the opposite of success. And it's actually a part of success, right? Failure is actually a part of success. So I don't, yeah, okay, anyways. Okay, and so 2 years after being in private practice, I ventured into implants, deep bone grafts, GBR. I went into an occlusion masterclass in my study club, and some of them from Singapore and Australia are here tonight. So hi guys, John and Jess, Charles, Carmen. This is like a reunion. We used to meet like daily on Zoom during the early days of MCO. Yeah, amazing. And so yeah, I thought like full mouth rehab solved everything. It's about fixing TMDs, occlusal prematurities. Anyway, long story short, I joined the mastership of Biomimetic Dentistry. I'm not fully like certified. This is a mastership program. So yes, it's a training, 1 year training with the Allmans. And so now I'm currently mentored by David and David Allman, Ashley, Dave Walt. And so ever since going to BRD, my brain has been challenged and rewired. I had to learn and relearn, also unlearn a lot of things. And as I shared what I learned on Instagram, messages started pouring in asking and so we kept the conversation going and it was exciting. So Vinish's invitation came at the right time. So on behalf of everyone here, thank you, Vinish, for organizing this. Thank you, MBA Toastmasters and Darren from Restaurant for sponsoring this meeting so we can get biomimetics out to more Malaysians. Okay. All right. So I want to start by introducing you to the concept of the tooth-death spiral. And because this is a popular concept that us as dentists need to recognize and talk about more. So when we look at this tooth-death spiral, or it's very funny, some people call it the money tooth. Like, would you call this the money tooth cycle or the tooth-death spiral? It's actually a tooth-death spiral, right? So we see an intact tooth at the 12 o'clock, and then okay, maybe a few years later, I mean, the patient presents with proximal caries. So we do a DO filling on maybe the 1/6, okay? And then, but after a few years, there's leakage. Patient presents with secondary caries, and it proceeds to become like an MOD, which after then fails after a while. And then what do? We crown it, right? So after the crown, hey, the pain is not resolved. Or the pain is resolved, but the symptoms come back after a few years. And then we send them for endo, or we do the endo ourselves. And then unfortunately, after a few years, it fractures. And after fracture, we can still can do post-crown, never mind. Then after that, extraction, and then lastly, an implant. So what I'm trying to say is all of this could have been prevented if we as the restorative dentists, right, did the 1/6 filling well, right? And it's funny because most people don't talk about this because it works for the business of dentistry, if you think about it. Because out of one tooth, you get a patient coming back again and again and again. But what in the process, like what happens to our credibility? Do we want our patients to say, you know, I've been having pain and sensitivity for years, and this dentist like solved my problems, or I keep going back to the same dentist, and he just can't solve my problem. And it's like they recognize the tooth-death spiral, right? And so today it's not about, oh, you need to do this, or giving you the recipe for the perfect restoration. But more than anything, I just want all of us to ask why and start noticing patterns in our own work. Okay, so bear with me. There are going to be a few key pieces of literature that every biomimetic dentist knows, and I'm going to share some of them, and we're going to go through them together. So my goal today is not to convince you of anything, but it's just to make things as simple as I can and as clear as I can. So please let me know if there's any questions that you have, and we'll figure it out together at the end. All good? All right. Okay. Oh, sorry, that was supposed to happen. Yes, so the fundamentals. So this is the overview of today. So I don't want you to learn the what's, but I want you to be empowered by the why as well, why we're doing what we're doing. And in the era of Instagram and social media, it's very easy to copy and paste what other people are doing, even copy and pasting like treatment plans, right? Without understanding why. So what, why, and how, so that, of course, so that you can actually apply it, there needs to be an application. So yes, so these are the things that come to mind when I think about biomimetic dentistry. So firstly, we're going to cover making biology, knowing our bond strengths, preserving vitality, predictability, and repeatability. Okay, so firstly, what is biomimetic dentistry, right? Well, it's it's in the name itself. Bio is life or nature or biology, and mimetic means mimicking. So we believe that form follows function. Our teeth are very complex, and they are actually perfectly engineered to withstand the most force. Okay, so if you look at this photo from an article, it's actually there's a reason why enamel is on the outside and it's a protective hard shell, why dentin is inside and is softer, and why there's a DEJ or DEC. It's a dentin enamel complex, right? Because it's more than just a junction. That these and this DEC or DEJ fuses and holds these two very different materials together. Like enamel and dentin, they're so different. And so if you think of it like a car, it needs to be tough on the outside, but inside you kind of need airbags just in case you get into an accident, the car gets smashed, but we don't die. So it transfers the stress to the airbag, which works to absorb shock. Okay, so the DEC prevents fractures, it stops cracks from further propagating. So mostly, sometimes when you look at cracked teeth, as we excavate and clean the tooth out, we notice that the crack actually stops at the DEJ. So you can see cracks in the enamel, but it doesn't get through to the dentin. So this is because of the DEC. So that's what the DEC does. Yes. And also, if we notice, there's actually more dentin than enamel. Interesting. Okay. So this is a quote by Pascal Mani. If we as dentists want to replace what has been lost, we need to agree on what is the correct reference. And for the restorative dentist, the unquestionable reference is the intact natural tooth. Think about that for a minute, right? If we truly believe that the tooth is perfectly engineered, then we know that the only way to replace what has been lost is to mimic nature. So if we are restoring a tooth, we're using materials that closely resemble that of the tooth. So we want to copy the very nature of the tooth. And when we restore it to how it functions originally. Okay, I'm not talking about like copying as in anatomy and everything. It's like the very essence of the tooth. Okay, not just like the top. Okay. Secondly, biomimetic dentistry is about knowing your bond strengths. It's restoring a tooth that's connected at 30 to 50 megapascals, top to bottom, side to side, and front to back. Okay, so it's a bottom-up approach. And if you look at this restoration that I did on the right, it looks pretty, it makes me feel good, but guess what? The patient doesn't care. Okay, patients care if we solve their problems or the sensitivity or the pain. Okay, so this, like, it doesn't matter. So remember that figure 30 to 50. We'll go more into that later. Okay, so biomimetic dentistry is also about preserving vitality whenever possible. And we do this by using certain techniques like maximizing our bond strength or even removing cracks in dentin, knowing our caries removal endpoints. We will talk about that when we discuss the how later. Okay, you will know this. Fourthly, predictability. And last time it used to be quite like wishy-washy for me. I'm like, okay, if you have pain in the future, then you need root canal. If not, then okay. But if I was successful, I never knew what contributed to that success. Or similarly with my failures. And so the last one is it repeatable? Like, can we make it happen again? So let's go into the fundamentals. This is the whys. Okay, so we finished the whats. Let's go into the whys. Is everyone good? Is everyone following? Oh, good, right? Okay, good. Okay, so bonds versus stress. When we're doing a filling, we need to think about bonds versus stress. So this is the ultimate foundation of biomimetics. Okay, we need to remember that composites shrink, resins shrink, and there's always competition between the maturing bond strength to your dentin and the developing shrinkage stress of our composites. So that's like a tension. Okay, and if you look at the picture, bonds versus stress, like firstly, we need to identify what causes stress to our restoration. So things like high C factor, just bulk filling, composites, or I'm not talking about using the bulk fill material. I'm talking about just like literally bulk filling a class 1 cavity, or polymerization shrinkage stresses. And when our restoration isn't bonded properly, the stresses are transferred to the tooth. So that's why we see delamination, cracks under fillings, pain, sensitivity, things like that. So it's actually our job as dentists to manage these stresses. I know our job as dentists is already like very stressful. We need to manage our own stress, but we need to manage our composite stresses too, okay? So this is a video that I want you to watch. It's a real-time imaging of what happens during and after polymerization. Okay, so this is a composite. It's playing, right? All good? Okay. So it's bonded with a universal bonding system. And you can see as it's being light cured, you look at the floor, you start seeing delamination, right? There's a gap right on the floor. Okay. And even after you stop your light cure, the gap formation continues. Yeah. So meaning the bond isn't strong enough to overcome the stress. So it doesn't matter how strong our bond is. If we don't know how to manage the stresses, we're basically ripping apart our fillings after filling them, okay, without even knowing, right? Because we can't look at the floor, okay? So bonds versus stress. Second thing is enamel versus dentine bonding. So if I were to ask you, which bond's better, enamel or dentine, what would you say? Does enamel bond better or dentine bond better? So anyone not trained in biomimetics, or even, I mean, like the general population, right, would say enamel, because that's what we've been taught in school. That's what we've come to believe. So the question should be changed to which is easier to bond to, enamel or dentine. And if this is the question, it should be enamel. Enamel is very easy to bond to. Okay, why is this? Enamel is dry and filled with inorganic material. It's literally the first thing we learn in like oral biology in year 1 of dentistry. Enamel has 95 to 98% inorganic content. So how I think about it is, it's just like sticking a post-it note, right? Imagine you stick it to a piece of glass with it, like a wet surface, it just wouldn't work. It wouldn't stick. Or if you stick it to a drywall or paper, then it works better, right? So like it's easy to bond to dry surfaces, not wet. And so when we're comparing numbers, enamel's microtensile bond strengths go up to about 30 megapascals. And because this is because enamel is brittle, so the bond won't break. It's the enamel itself which starts to break because it's brittle. While when we're talking about dentine, the microtensile bond strengths of dentine go up to 50 megapascals or more. So conclusion is bonding to dentine is hard because it's wet and we need time. We're going to talk about this later also. So in biomimetics, the number that we aim for when we talk about bond strengths to dentine is 50 megapascals. That's because this is the cohesive strength of dentine. Okay. The problem is it's not easy to get these numbers in the mouth. Okay. In the lab, people get 50. Pascal has gotten 70. Tagami has gotten 80. So today we're going to learn how do we get these bond strengths. All right. All good. So we're done with what and the why. Let's get into the how. This is where it gets interesting. I know everyone's like, yeah, just tell us how to do it. That's why I'm here. Okay, we're gonna start easy. Okay, so we're gonna cover photography, rubber dam isolation, CDD, curious detector dye, IDS, and resin coating, and DWT, which is decoupling with time. All right. So photography. I have to put this here. It's something very basic, but I have to put it here because I'm fully convinced that the only way someone improves is by documenting their work. All the best dentists I know, and probably that you know, take photos of their work. If you don't, like, you cannot see your mistakes, and you literally cannot see your mistakes. And with that, you can never improve. I mean, not never, but like you improve slower. So start somewhere. If you don't have a DSLR, get one from restaurant. You're welcome. But yeah, shameless plug. And also magnification is super important. And I'm using a Pentax 5.0. But if you can't afford loops, there's a little hack, kind of. Most of the times when I'm using my loops, when I reach my caries removal endpoint, my CRE, I remove my loops and I take my camera to take a photo, and then I zoom in to check my preps or my CRE. So that's why photography is important. It's a small little hack. Okay. So second thing is rubber dam isolation. Okay. So I love the Brinker set from Coolteen and also Sanctuary Dams. And the sad truth that everyone knows is if we compromise our isolation, we compromise our bonding. We all know this, right? And the truth is we can't do BRD without rubber dams. Here are some photos of my rubber dam journey for some of you rubber dam lovers. I only started rubber dam last year. Okay, so like I'm no professional in rubber dams, but like as we keep going, we keep improving. And now like I do every single restoration under a rubber dam. Like every single bonding, every single cementation of onlays, like it's all under rubber dams. And my nurse knows this. And all the nurses knows that. Okay, so I started off with Nictodams, but now I mostly only use Sanctuary. The purple on the top left is the non-latex one. Some of the pink ones are, it's also from Sanctuary, but it's a little thinner than the silk blue range, which is the one that I normally use. And so the thing about rubber dams, I don't want to talk too long about rubber dams because you can learn that from Sean. Okay, you just got to start. Okay, and so there's this quote: people do not decide their futures, they decide their habits, and their habits decide their future. Wow. Okay, so it's not your habits, it's not your goals that decide your actions. Okay, no dentist, right, wake up in the morning and say, okay, you know what, today I'm not going to use a rubber dam. Nobody does that. Okay, so even if it's hard, even if it's leaking, it will leak. Just buy some liquid dam and like make that thing stop. So even if you can't figure out how to invert your dam, just put on the dam first. Okay, go for a course, take Sean's class. In Malaysia, we have so many dentists and people always complain that there's like oversaturation. But that also means there are so many more heads to think together and learn from. They're like people like Navin, Hazwan, who are here tonight, Melvin, like Ivan, Sindhu, learn from them and keep the conversations going. It's really a blessing to have a community, even though online, but it is a blessing to have a community where we learn from each other. Okay, let's go to the third thing, which is CDD, caries detector dye. So you've seen it everywhere on Instagram, but let's go a little deeper. Okay, CDD is a propylene glycol-based fusion dye. And so we apply it on caries teeth to help us achieve our CRE. And CRE is basically how much caries we remove and when do we stop removing. So our caries removal endpoint. Okay, and I want you to think about this. Since we were in dental school, right? Since we were in uni, every time we ask our lecturers, sir, ma'am, like how much caries do we remove? The answer will be like, oh, just remove the soft caries, the infected dentin. Everyone hear that before, right? It's like standard answer. Or like just remove, I know one, just remove until you don't feel the soft, like you just remove until like you let your slow speed handpiece lands on hard caries. So there's this confusion or frustration with not knowing how much caries to remove, not knowing how soft is soft or how hard is hard. There needs to be an objective standard, not just following our feelings, okay? Because hardness and softness is feelings. It's not scientific. So let me introduce you to one of these papers, which is Fusayama 1988. And he talks about the significance of using a caries detector dye. And so Fusayama said this: it is quite surprising that we dentists have up to now performed caries treatment, our most important professional duty, while relying on such an ambiguous means of detection which has no scientific basis. Ouch, no scientific basis. That's so sad. Yeah, because feelings are not scientific, right? We need to visualize our demineralized dentin, our affected dentin, then only can we properly remove caries. And there's another paper that I quite like by Anderson, 1985, This study design is quite interesting. They got students at the University of Michigan to remove caries on extracted teeth, just like us last time when we were in dental school. And then after they remove the caries on the extracted teeth, they show it to the lecturers. Okay, so the ones that are approved by the lecturers, they collect them and they stain them. So the ones that they stain are already approved by the lecturers. Lecturers say, okay. But out of the ones that the lecturers approved, 59% of them stained at the DEJ. That's so sad, but they were already approved by the lecturers. So it's not that the lecturers are lousy, but it's actually physically impossible for any one of us to visualize caries just based on color and texture. So it says both color and hardness texture have inadequacies as consistent guides for caries removal. So the take-home message is, if you're not using CDD, that's a 59% chance that you're leaving caries behind. And now we know that CDD is important, but how do we use it? Okay, to know this, we'll have to visit another paper. Okay, today we're just gonna look at papers. Okay, yes, how do we effectively use CDD? It's one of my favorites, Almond Money 2012. So this paper is based off of Fusayama's paper. So I love Fusayama for what he's done, but one thing he failed to do was to show you, where do you stop removing caries? Do you just remove all the pink and the red that you see? If we just remove all the pink and the red that we see when we stain our tooth, in many cases, we would be perforating the pulp every single time, right? So there's a guide to achieve your caries removal endpoint. You can read the paper. You have to read the paper. It's a really good one. But long story short, TLDR, okay, this is the conclusion, that to avoid unnecessary pulp exposures, we need to know our anatomy well. And so when you know where the pulp is, you're able to keep the pulp alive. You're able to avoid exposure. So 3 mm axially, 5 mm occlusally, that's the measurements. I measured this using a perio probe, and it's 5 mm from the occlusal surface, and then 3 mm from the adjacent tooth margin. This paper is available online for free. Go and check it out. If you want, I will send you the article, and I highly encourage you to read it and let the literature speak for itself, okay? Okay, this is a case documentation that I wanted to show you. This was an old filling done before I started BRD or I started any protocols. I wasn't even using rubber dam. Okay, so the patient came back with prolonged sensitivity. So I'm like, okay, how? So I had to swallow my pride and open up the filling. And at that time, I just got CDD. And I remember I just started like the first few weeks of the mastership. So I'm like, okay, let's just stain it. Let's see. And after I stain it, true enough, in the second picture, you can see the whole thing was stained pink. I'm like, wait, what? I thought I already like filled this well. So then I removed the areas with pink. And then I stain again, which is the third photo. After I stain, I wash it off. Like, quite sure no more already, right? Like, should be, right? But anyways, the first picture again, they're still pink. Like, what? So that's what the Anderson paper was talking about. We would miss caries 59% of the time if we are not using CDD. Okay, so after about 6 applications and removal of caries, I like wanted to cry already. I finally achieved my PSZ, which is the peripheral seal zone. So this PSZ is this 2 mm zone within the DAJ that you want clean. So meaning no pink haze, just clean. Okay, and so you can see that in the area that I labeled 15 MPa, 15 megapascals, I didn't remove the dye there because remember, if I did, we would have perforated the pulp. So thank God we managed to redo the filling following this protocol, and the patient has been symptom-free since then, thank God. So things work, like use your CDD. Okay, so now so there's so much talk about CDD. We know that it's super important, and you would think like, wow, this thing is so useful, it must be expensive, right? And so if you're broke, I mean, actually most dentists are actually broke because we spend way too much money on dental stuff. But if you're broke, it's true. You know it. Everyone's like, yep, It's true. But anyways, don't worry, CDD is cheap. And the most common question I got so far about CDD is not even how do you use it. It's like, where do you get it? Okay, and so I get mine from NTC Dental, and Doris Gunn from NTC Dental has very kindly offered to give tonight's webinar participants a 10% off, which makes it like $51 per syringe. And one syringe literally, okay, not literally, okay, but one syringe will last you forever. Okay, so if you get a packet of 4 syringes, like share it with your friends or something, or yeah, and it's only like 51 ringgit for one. And this is like the cheapest material to start applying PRD. I think you can get also like the 2 in a pack. That's the one I normally get. So I've never gotten it this cheap before. $51 is just crazy to me. So take a snapshot of this and then send her a message if you're interested. Okay. So, and one tip I have when you're using this, you see the picture on the top left, like that it comes with a black tip. Don't use the black tip. Okay, you're gonna waste so much. Okay, you see the lower photo, the white cap, just use that as a cap. And then when you want to use it, just use a micro brush to soak up some CDD, close it back. Like it lasts forever, trust me. Okay, so we're done with CDD. Let's go on to the next topic, which is the next how, which is adhesives. Okay, so when we're looking at these 3 bottles of adhesives, these are the gold standards that kind of predictably get us to 50 megapascals of bond strength. And the middle and the left one are by QRA, and we can't get QRA in Malaysia. The one on the right is Optibond FL. That's the one that I'm currently using, and I get it from Altis Pro. And one thing to notice is all these are 2 bottle systems. Okay, why is that? Like the problem with bonding to dentin, like we knew that, remember dentin was wet, right? It's not dry. So in a 2-step bonding system, you have your primer and adhesive, 2 bottles. So firstly, okay, so this is your dentin, it's wet, remember. So firstly, you need your primer, which is hydrophilic, water-loving, because dentin is wet. So your primer is hydrophilic so that it's able to penetrate dentin. And then it bridges your adhesive, which is hydrophobic. Okay, so yeah, adhesive, which is hydrophobic, which is your next layer. So primer, adhesive, so that your next layer, which is composite, which is also hydrophobic, is able to stay on better. There's no leakage, there's no transudation of your fluids. So it's able to keep it hydrophobic for a longer time. So the most common question people ask is, what if I'm using a universal? And in this 2-step bottle system, there are hydrophilic and hydrophobic. In a universal, everything is in that bottle. So there's a lot more chemistries being mixed. And you can still use universals. It's not like they don't work, they do. Universals work, but it's gonna be harder for you to get and actually maintain your 50 megapascals, which to us is what we aim for. Okay, you can still use universals. Okay, so I grouped this together, IDS, adhesive resin coat, because you use your adhesive for IDS. Okay, IDS, what does it mean? It's literally also in the name. Immediate dentin sealing. It's sealing freshly cut dentin, meaning if you're doing an indirect onlay crown, you're not waiting for the cementation day to seal it with your bond and adhesive cement. You're doing it immediately after you prep. Like once you prep, you can see the picture. Like after you prep, you etch and you bond it, you seal it right before you take your impression. Okay, and this is a huge advantage because in that 2-week period while you're waiting for your prosthesis to come back from the lab, you've sealed your tooth from bacterial ingress, from leakage, and that will prevent sensitivity. And the best thing, in that 2-week period, your hybrid layer is maturing. So remember I said dentin is hard to bond to? Well, one of the factors is time. And when you IDS, you allow time for your hybrid layer to mature. Okay, why IDS? Okay, so again, we have to look at some papers. This is a key paper on IDS, Money 2005. where they compare delayed dentin sealing and immediate dentin sealing. So in the delayed dentin sealing group, you prep your crown or onlay, you temporize, and then you take your impression and then you send it to your lab, right? The normal procedure, like prep, temporize, impression, send to lab. But in IDS, however, you prep, and then immediately after you prep, seal, and then you take your impression, temporize, and then send it to the lab. So the only difference between DDS and IDS is sealing your dentin immediately after you prep. So let's look at the bond strength values. True enough, the delayed dentin sealing has lower bond strengths. The IDS values have 400% higher bond strengths compared to the DDS group. The numbers look great. We can achieve that 50 megapascals we're aiming for. Again, to recap, why IDS? Freshly cut dentin is the best surface to bond to. Once contaminated, bond strengths decrease. And there's a 400% improvement in bond strengths. The advantage, why do you have like an increase in bond strength, is because you've allowed your hybrid layer to mature and develop over the 2-week period. And so this reduces inter-appointment sensitivity and bacterial ingress. I have a friend, she used to be against IDS. Over the past months, she's like, Kate, I finally like IDS all my preps, and I'm shocked at how during the second appointment, during cementation, the bonding appointment, she used to always give LA, because whenever she would remove her provisional, it would be very sensitive. And she said she didn't have to anymore because she has already sealed it. So IDS works, okay? Another example of, I know a lot of people are like super convinced by IDS, is because after they do their IDS, they temporize, right? And then they temporize using like a resin temporary resin. And that thing bonds because they didn't like remove the oxygen inhibited layer. And so one of the caveats for IDS is you need to remove your oxygen inhibited layer after like cure under glycerin, okay? So yeah, and the thing bonds. So they're like fully convinced, oh, like I can't get it off. It must work. Okay. So, okay, IDS and also resin coat. Resin coat is just simply 0.5 mm flowable on top of your IDS. How I do this is I use a perio probe with the 0.5 mm ball end. And so I just like run it over my IDS layer. So what the resin coat layer does is it provides strength to the hybrid layer. It also thickens the adhesive layer, especially when your protocol during your cementation is to roughen or aerate your prep. Then yeah, it thickens it so that when you are aerating, you don't aerate your adhesive layer, your IDS section. Yeah. So, or if you're using an unfilled adhesive like a universal or even clear fill SC Protect, those are unfilled. So if you add a layer of flowable, it reinforces your hybrid layer so that it can actually resist transudation of the fluids, which causes sensitivity. Okay. So, oops, yeah. Yeah, this is what it looks like. Okay, the first layer of IDS and then your resin coat on top. And if you look at this case of mine, you can see what IDS and resin coat looks like. The left is my onlay prep, and the right photo is my bio base after IDS and resin coat. So it should look kind of matte and frosty and sealed. Okay, you can see the difference. Okay, so it brings us to like the last point. Okay, I don't expect everyone to get like CDD or go ahead standard adhesives. Clearfield SC Protect is like 1,000 ringgit, more than 1,000 ringgit per bottle. But there are things that we can do for no extra charges upon us, absolutely free. Malaysians love this, and it's decoupling with time. Okay, I love this because anyone can do it. You don't have to be a great clinician, or you don't have to like buy any extra materials to decouple with time. So to recap and freshen your memory, earlier we said that composites shrink, right? So, and there's a competition between stress and bonds. So if we want to learn how to effectively bond to dentin, we need to understand that bonds take time to develop. This bond doesn't happen instantly. Okay, this isn't an okay. Wait, okay, and this is one of the studies by Liu. You can see after 5 minutes, the 90% of the stress, polymerization stress, was eliminated. Okay, and in the 30 minutes or more, so you can imagine like what happens during your 2 weeks. Your IDS is maturing, and there's like no more polymerization stress. It's very stress free. Okay, so this like slower dentistry works sometimes. And sometimes it's not easy to explain decoupling with time, but one simple example is, you know, those peel and stick hooks, those hooks that you can get from Mr. DIY or hardware shops, or like 3M does them too. So the back label would always say like clean the surface, and then you peel off the sticker and then you stick it on the wall. But after that, like every single hook would say this, like wait like 12 hours before you load it with your keys or your clothes. Okay, like why do they say this? Why do they say this? Like why do they say wait 12 hours or even 24 hours or 6 hours? You get it. But because they understand that bonds don't happen instantly. We need time for the bond to mature. And so you can see it's so strong that the guy can like hang off it. Like Shopee has the weirdest thing sometimes, but yeah. So we apply our bonding system, and then we wait 5 minutes, and then we start packing our composites in incremental layers. So the moment you cure your bond, that's when the clock starts. Okay. But in this 5 minutes, everyone's like, "Ayo, I have to wait 5 minutes. You know, I work in the government, you know. In 5 minutes, you can resin coat, which is normally what I do. You can build up with your rebond fiber, reinforce it, or if it's a class 2, I normally build up the wall first so that I don't stress my developing hybrid layer on the floor. And it works because I'm very slow. I usually take like 3 to 5 minutes to set up my matrix and my wedge to get a good seal anyway. So it works for me. Or so you can resin coat, reinforce with rebond fibers, or build up the wall, or like tell your patients how important slow dentistry is. They're always like, okay, good, take your time. And like, okay. So what this 5 minutes does is it gives time for your hybrid layer to mature before you start stressing and pulling it. Okay, all right. Okay. I'm done, okay? I'm done. Okay, but so to recap, we learned some ways to maximize our bonds. So like caries detected dye, IDS, resin coat, decouple with time. And just having this knowledge would make life so much more predictable for you. And I think the joy of biomimetic dentistry is taking out the guesswork out of things. Dentistry life is already quite stressful enough. But before I end, I want to show you some of my mistakes that I've done. I know this is everyone's favorite part. They're like, yeah, show mistakes. Okay, so this is a case just late last year, 1st December. I'm really not proud of this, but I just wanted to show my setbacks and failures. It was a patient who had sensitivity, and you can see there's an amalgam and GIC filling there. So you know that it's an unbonded filling. And my mistake was I didn't know the measurements of the pulp. Like remember the 5 mm and 3 mm? So I didn't know where the pulp was. So I couldn't preserve vitality, and I actually perforated. So after I perforated, what I do, put Dical and Bichabon all over the floor. Like I'm cringing as I'm looking at my own work. And if you have a habit of doing this, when you're just like covering the entire floor with Bichabon, you're actually blocking the amount of tooth structure that you bond to. So whatever bonding system you're using, it works less because you're ultimately blocking your own bond. So, and then I rewalled, and then, oh my goodness, I even put stains, and it's like the most horrible, like I would never post this up. It looks just like absolutely terrible. Okay. So, but the thing is, she came back just mid this month, like 14th July, recently. She's like, Dr. Kate, I really cannot. It was painful last week, but now it has lessened. We all know what that means, right? Painful last week, now not painful anymore. Oops. So true enough, I checked it and it was non-vital. So we proceeded with endo. And as I was removing my old composite, you can see where the arrow is. I noticed there was leakage underneath my old filling. And the funny thing is, you know, the old filling was already done under rubber dam. So it just proves to me that rubber dam alone is not enough. You need to truly know why and how you're strategizing your restoration for it to be successful. Like strategize it well. Okay, so I completed the endo, CDD again, like make sure that there was no more pink. This was just like immediately. I don't have the cage removal endpoint photo, but yes, it was totally clean. And then reinforced my hybrid layer with ribbon fiber and then prepared it for an indirect onlay. Okay, so learn from a mistake. Don't perforate the pulps. Okay, and this one was a patient who came in with sensitivity on 4/6, and like this is very weird because she came in and she was like, I want a root canal and redo my filling. And I'm like, oh, why do you feel like you need a root canal? She's like, oh, it's been refilled every 2 years for the past 15 years. I'm like, that's 7 times. And I'm like, okay, so do you want to try a way to solve this without having to root canal your tooth? She's like, okay, but I just thought that I needed a root canal. And so sometimes patients like they don't know what they're saying, but yeah, they thought like root canal will solve all their problems because she was having sensitivity. So when I removed the old filling, there was caries underneath, there was cracks in the dentine as well. And so after establishing my caries removal endpoint, and removing the cracks, I sealed it up with IDS and resin coated and restored it with a indirect tabletop non-retentive overlay with Emacs. Okay, and this is the last case. This patient is a friend of mine, and we completed her endo. And while waiting for my hybrid layer to mature for the first 5 minutes, remember the 5 minutes DWT, decoupling with time, we build up the wall first and then reinforce the hybrid layer on the floor as well as ribbon wallpaper. And so a direct restoration was done. Okay, and so as we come to an end, I know not everyone has the luxury of using these materials, or even most times, like time is a luxury, especially with people with high patient flow. But you know, what you do reveals what you believe, and if you know and trust the science, your work will reveal that. If you know how saliva and moisture contamination will affect your bonding, your composite bonding, you will use rubber dam. And if you know how how the shrinkage of composite moves, you will decouple with time. You will use small horizontal layers. So there's a lot more to BRD. There's like fibers, biobases, DME, crack dissections. But this is the best I can do tonight without drowning you guys. Okay, so thank you, Vinesh, for having me. Thank you, everyone, for listening and hanging out with us on a Thursday night. I'll leave the time for Q&A, I guess.
Hi, thank you again, Dr. Tan, Dr. Kathleen. So it's a big, even I learned a lot of things. I hope everyone also learned a lot of things. It's something, a new concept. I mean, yeah, it's true like how you can't learn everything in just 1 hour, but at least it's an eye opener. And there's a lot of products that Dr. Kathleen have recommended for us to use. So we can use that, and we can test run first, and yeah, we can see how it goes. So we have a few questions. Before that, I would like to give some shout outs just to see from where we are from. So most of us are here from Malaysia, I'm guessing. And do we have anyone from Singapore? Anyone from Singapore?
Charles from Singapore.
Yeah, we have some participants from Singapore. Any participant from Australia?
John and Jess are from Australia. They're my study club friends.
So we have people from Australia as well. Do you have from any other countries who want to give a shout out? Singapore, WBC, Sarawak considered overseas. Yes, currently Sabah Sarawak is considered overseas. Yes, that's good. That's good. Anyone from the European side? Hi, So anyone from the European side? I'm just going through this so that I give Dr. Kathleen some time to rest before she answers the questions.
It's okay.
Oh, we have from Philippines as well. Hi, Misty Nevels.
Oh, she's my BRD senior actually. Let's see.
Hi,
You should-
hi. Thanks
You
for
should be
joining.
presenting this.
Thanks for joining. Anyone else from any other places? From Indonesia, from Europe, from US? Anyone else from there? No other response. But yeah, we got quite a good from India. Hi. We have
Hello.
RP CM from India. Hi. Thanks. Oh, from Indonesia. We have from Indonesia as well. Steven Untono. Oh, now you're an international speaker, Dr. Kathleen.
You are finished.
Congrats. We had before you go to question, I have rest the throat a bit. So I just tell we had full house, 500 people. That's very good. I'm very happy. But at the same time, I was a bit sad because I was getting a lot more messages telling that doctor can't enter full already. So I do not know any other platform which is more than 500. So, but it's a very good sharing. All right. So, are you okay, Dr. Kathleen? You're okay to answer the question?
Yes,
all right. So, yeah. So now we go to the Q&As. So let me share the screen first. I have made our from MDA. They have helped to share the screens a bit. Yes. Can you see, Dr. Kathleen?
Yeah.
All right. So the first question is, which one is better, the red or green CBD?
Yeah, I get this question a lot also on Instagram. I tried them both. With Ultradent, if we are talking about Ultradent, it's Sable Seek and Seek. And the one that I like more is Seek, the red one. I've tried the green one first, but I find that because, okay, I mostly work on posteriors. And when we are repairing, like normally all these broken down teeth are mostly posteriors. And it's already, even with rubber dam isolation, it's already so, like the light is already so little at the back of the mouth. And so the dark green is really dark and really hard to see, especially in like teeth with amalgam tattoo. Like you really don't know which is the dye and which is the like stained teeth, like amalgam stained teeth. So I always prefer the red. But I mean, I know Leandre recently got the green because the red was out of stock. So I guess like you can really choose whatever you want, but I just prefer the red. It looks better too.
So personal preference is red. Like that. So that's good. Even red looks nicer in photos also.
It does. I feel so too. But that's not a very good answer. So
I mean, aesthetically it's quite important. So yeah, I mean it's good. Okay. So hope that answers the question. Now we go to the second question. Do you put IDS flowable on enamel as well?
You don't. So IDS is immediate dentine sealing. So enamel, you would when you're preparing your final bio base, what people normally would do is like kind of refresh the enamel, meaning they don't want like a layer of bonding agent on the enamel. Because enamel is easy to bond, remember? See, this paper is still here. So you can bond in enamel immediately. That's why like for veneers or things that are like just on enamel, we don't have to pay any special attention to them. They bond quite well.
All right, thank you so much. So IDS is stand for dentine. D is dentine, so only for dentine. Please take note, guys.
No, I was
question,
confused with this too last time. No worries.
Next question. Hybrid layer needs 2 weeks to mature. What suggestion would you give for same-day crown using CEREC?
Hybrid layer does not need 2 weeks to mature necessarily. If you remember the graph that I showed just now, the polymerization shrinkage, it actually kind of fully matures in about like, what was it? Like 5 minutes was 95%. And hold on. Let me pull up the graph.
Okay, no problem.
I can't really show you guys, but okay. 5 minutes is 90%, 30 minutes, 95%, 100% is 120 hours. That's about, it's not so good, but about five days plus. So to answer your question, hybrid layer does not need 2 weeks to mature. What suggestion would you give for same day crowns using CEREC? The good news is when you're using your CEREC, probably you would need like 1-2 hours or maybe a few more hours. In that in that time, your hybrid layer has already matured, because after 5 minutes, after 30 minutes, you're good to go. Like it's like 95%. You're okay to load it after that. Yeah, so same day crowns, same day onlays, they work.
All right.
I
So
would need
for
the
same
2
days, onlays and crowns, 5 minutes is good enough. But I think
I
it
mean-
can go up to, like, since we have to wait for serrated crown for almost few hours. So yeah, it gives up to 95%. I hope that answers the question. Thank you for that question. Next question we have Dr. Kathleen. Can you just explain again on IDS and RC and what method you use to perform IDS? Thank you. For this,
Okay.
it's long.
Okay. IDS is immediate dentin sealing. So as I mentioned, I use my adhesive. Like you would use your adhesive for immediate dentin sealing. So if you're whatever bonding agent you're using, use that. For me, I'm using OptiBond FL for my IDS layer, and then I reinforce that using with my RC root canal. I'm like, oh my god. With my resin coat layer, okay, which is I'm using G-Anil flowable. But okay, recently I realized that it's not flowy enough. I mean, it is flowy enough, it's a flowable, but I would prefer like a more flowy one. You can really use whatever flowable you want for resin coat. For IDS, use your bonding agent, your adhesive. So if it's a universal, if a universal is all you have, use that.
Okay, thank you so much. I hope that answers the question. Do you always air abrade your bio base?
Yes, but I don't have an air particle abrasion unit. So normally what I do is I just like refresh it by refining with your like yellow diamond
Fine.
finishing burr, or yeah. But technically you should air abrade because you want to kind of reactivate the monomers to bond to get ready for your bond. Yeah, if you have an air abrasion unit, use it. It would help. Definitely.
Not all clinic will have abrasion, but you can compromise with.
My AquaCare is not here yet.
Wow, that's on the way soon.
Not yet, but yeah.
Next question: can we repair IDS or biobase?
Okay, so the reason why we do IDS is so that, okay, why do you IDS and resin coat build up your biobase is so that any failures that happen, it's basically why you IDS and resin coat is to strategize your failures. So you want your failure to occur above your hybrid layer. So things like even if it debonds above your hybrid layer, and so it doesn't rip out your entire hybrid layer together with your dentin and then like expose your dentin again. So the reason for one of the reasons for resin coat is also to what we call a secure bond. This secure bond strategy is so that to protect your hybrid layer. So any kind of failure that happens above your hybrid layer. So you don't have to repair your IDS or biobase if done well. But if it rips apart, then there was something wrong with your IDS, you would have to redo it. Yeah.
Right. Thank you so much for that. Next question, Dr. Kathleen, okay to move on?
I'm good.
All right. Everyone else is okay. Hope everyone else is okay. Okay. Next question we go. Where does DICAL or GIC stand in BRD concept? Yeah, actually, I wanted to ask regarding the GIC as well.
I mean, we don't use DICAL and GIC in BRD because remember like my failure that I showed, like I just like DICAL and Vitrabond the entire floor, but it's actually blocking, like I'm blocking myself. So I'm like shooting myself in the foot for like blocking my own bond.
Okay.
Yeah. So
in that
there are
regard,
people
I just want to add a bit. GIC is also in a way is resin based. So I think once you put the resin RC, I think it works as well. It helps. I'm guessing.
Sorry, Vinesh, can you repeat?
No, I said like you said, like, you don't use GIC or like even GIC is part of ionomer cement. So they also like that's why you have the RC2. Basically, RC is replacing the GIC, I'm guessing here.
Resin coat is not GIC. Resin coat is a flowable. It's not GIC based. So if you're talking about RMGIC, those are not flowables. You want to use a flowable composite.
Correct.
Yeah.
Next question was quite a long question. There's a post by Dr. Patrick Chalalang, hopefully I'm pronouncing his name correct, saying that we can live and bond to carious dentin. Can you elaborate a little on that, and how's the prognosis since we are living the pool of caries near to the pulp? Thank you, Sifu, with a cute face.
Oh, that's very cute. But okay, this is a really, really good question, and I think everyone can benefit from this. When we are leaving carious dentin on the floor, we need to understand that you know, when we are using our caries detector dye, right? There's affected dentin, infected dentin. So all these have different, we call it hierarchy of bondability, meaning we recognize that every single substrate that you bond to have different bondabilities and different bond potentials. So your enamel, you're bonding at 30 megapascals, your superficial dentin, 45 megapascals. Your deep dentin is like maybe 30. When you're bonding to carious dentin, carious meaning like what, affected dentin, right? So that's why I say don't leave the pink haze. But if you do, not disastrous, because it bonds to affected dentin at about 15 megapascals to 20 megapascals. So you're still getting bond. Like carious dentin still bonds. Don't worry. Like you can, the prognosis of leaving a pool so near to the pulp is that I also asked this during my mastership program because I'm like, okay, I'm not convinced. But yes, the caries just, because it's sealed so well, it just is inactivated. It doesn't have any of the things it need to like proliferate.
Oh, okay. That's
That's why things like the kind of failure that I showed works. When you leave that layer of affected dentin, 15 megapascals, it still bonds. It's not that it's unable to bond. So I think like it's our like paradigm shift of thinking that affected dentin and affected dentin needs to be excavated. It doesn't. It's still dentin, and there's still hydroxyapatite inside that dentin that is able to, the collagen is still able to bond towards our adhesives.
all right. Thank you. That's something quite interesting also. Thanks so much for the input there. What about our X flow? Can we replace is instead of using rebond?
Okay. These two, although they are under the fiber category, it's not interchangeable. Like they work differently. So EverX Flow, EverX Posterior, they work to kind of strengthen the teeth. Rebond reinforces our hybrid layer. Rebond kind of deflects cracks. It redirects cracks. So that's why sometimes you would see on Instagram, if like there's a crack tooth, people use Rebond because it actually has the like when we look at one of the, remember the video that I showed just now of it delaminating? There's another video by, who is that guy? Dr. Sadar, I think. Yeah. When you put the Rebond there, even when you're using a universal adhesive, the Rebond is the one that gets pulled. So the Rebond kind of is like a protective coat to take all the stress. The Rebond takes the stress, not your hybrid layer. So your hybrid layer is not being pulled and not being destroyed in the process. Yeah. Hope that, does that answer? I hope that answers the question.
Yeah, I mean,
EverX Flow is to kind of strengthen your teeth.
Yeah, EverX is like basically a posterior, but then, yeah, as you say, it's
Fibers are great. Fibers are great. Oh, but remember that EverX Flow has a high shrinkage, has very high polymerization shrinkage stresses. So never bulk fill and EverX Flow. Okay, if you want, yeah, don't because it shrinks a lot.
Yeah, I believe that now we're going back to slow dentistry, so let us do like relax sleeve stages.
That's a great point.
Okay, next question is, hi, Dr. Kathleen, can you elaborate more on removing cracks? Do you generally chase cracks?
Okay, very good question. Cracks, I never used to know what does what do cracks do or how they function. But yes, if the cracks are in dentine, I would remove them. If they're in enamel, I would leave them, because remember, cracks in enamel are biomimetic. Enamels can fracture. That's why you always see crazed lines. And doesn't mean that when you see crazed lines or like these cracked lines in elderly folks, you want to kind of chase them out. You don't, because enamel has is brittle. You can leave cracks in enamel, but the moment they go into dentine and they like surpass that DEC layer, the DEJ, you want to remove the cracks in dentine because they're not biomimetic. A good way Davy Allman actually taught us this is, imagine if you're an engineer taking care of planes before they're allowed to take off. And one day you see a crack in like one of the, maybe like the cockpit area or something. Would you actually approve that aeroplane to fly off? You wouldn't, because like we need to, as dentists, we need to think, our brain kind of needs to like be rewired to think like engineers. If the cracks are not dealt with, they can propagate. And just because like we put a crown on top, just because we don't see it doesn't mean that it's not there. On like function, it can actually propagate, and sometimes it causes the tooth to suddenly be non-vital, but because like of the stresses underneath your crowns or your prostheses. So yes, remove your cracks in dentine. If you remove, okay, but if you remove until you cannot remove anymore, and if like you remove 1 more and you're already going to perforate the pulp, stop, like put rebond if you have, or yeah, just seal it up. It's better to keep the tooth alive than to remove until you like perforate the pulp. Hope I answered your question.
Yeah, which is quite nicely explained. So like you're telling, basically the enamel part, we try not to remove it, but for dentine, try your best, but not too much, and then try to cover it with your
yes. An interesting one, if you see cracks on a non-vital tooth, go ahead, like you can remove the cracks, because like you're not going to perforate the pulp. Just remove it, unless you're going to remove until you like have a perforation into like the PDL or something, then stop lah. But yeah, you know, just know that we are all human, and like you can stop. Like, you know, dentistry is so like stressful, but yeah.
Every step is technique sensitive. I do agree with that. Thank you so much. I hope that answers the question. Next question: if we achieve the peripheral seal zone, but the pulp floor is still heavily stained with CDD, should we move to follow the 5 mm occlusal and 3 mm proximal?
Yes, follow the 5 mm occlusal and 3 mm axially. So if you can, so the goal is always to remove as much as you can, unless you know that you're going to perforate. So yes, always follow the measurements. You're right. So just remove it. Yeah.
Okay, next one. How will it affect the bonding on hybrid layer if there is blood seeping into the cavity during matrix placement, and how would you manage it? Will you etch, bond, and build up as usual? Thank you.
Hybrid layer, meaning when you are establishing your hybrid layer, I'm assuming. So there's blood seeping. Firstly, okay, I mean, things happen. Like, it's not, I mean, yes, we should have our rubber dam, but sometimes blood seeps in. Sometimes your dam is not inverted. These things happen, yes. So if blood seeps into the cavity during matrix placement, just remove don't do anything. Just take a micro brush with some adhesive and wick away. Like you gotta try to stop the blood lah. I don't know how you're gonna stop the blood. Like if you started already, that's quite crucial to keep it isolated. But if you can stop the blood somehow and you want to continue, but you don't know how, then just take a micro brush with your adhesive. If you're using a two-step, then only your adhesive. No need primer already, because you already did your hybrid layer thing. I guess you already primed it. So just adhesive and wick away the blood, and then just build up as usual.
All right. Because the blood will effect, so we have to remove the blood. I think different people have different way of managing it. So this is one of the ways using microbiome adhesive. Maybe Dr. Sean can later share on how, because he does rubber dam. I'm pretty sure he has a lot of blood coming in, sometimes sitting up. Maybe he have more ideas.
Yes.
What does Reborn do to the tooth or restoration? And where and when do you put a Reborn?
That's a really good question. Ribbon reinforces your hybrid layer. But like I said just now, it deflects cracks. Yeah, it acts as a crack stopper. So anywhere I put ribbon in deep cavities. Obviously, if I have a tooth with a just enamel and very superficial dentin, I do not need that, because you can already achieve quite good bond strengths with just getting your peripheral seal zone and bonding to superficial dentin. You will get quite a good bond, and then you will still decouple with time anyway. So I only place it on very deep boxes, areas where I know. Okay, Reborn also, yes, Reborn acts as a DEJ. Okay, remember this. That's why people do Reborn wallpapering, to reinforce the tooth and to make it act like a tooth again. So yeah, in compromised situations, Reborn. So Reborn, put it in deep boxes, place it on cracks. If you go to the maximum and you know you can't go anymore, place a Reborn there. Wallpaper it if your cusps are too thin and you don't want to do an indirect, you want to do a direct, you need Reborn for that.
Okay, thank you so much. I hope that answers the question. So quite interesting. I've seen you using also a few times the Reborn in your case.
It's great. Yeah.
Next one. Hi, Dr. Kathleen. Okay, I think this one done already. Same.
There's
question.
no difference. Don't worry.
Yeah.
Just use the red one. Use the red one.
And then, okay, next one. How do you polish or get back margins after IDS plus RC prior to impression taking?
Polish or get back margins.
Right.
Oh, you mean like enamel?
I think so. That's what this question. I think maybe like after you're doing it.
I just use no worries. I just use a yellow band and then polish my enamel. Yeah, polish my enamel ring. Always remember that it's better to okay. If you have a choice of accidentally removing too much of your IDS layer and exposing your dentin, or accidentally leaving your IDS on your enamel, pick the second one. It's better to leave some IDS layer on the enamel than to accidentally, when you polish and you want to get that smooth enamel margin, you expose your dentin. Because we know, right? Dentin bonds better. I mean, stronger. So don't worry about the enamel.
All right. Thank you so much for that. Hope that answers the question. Next question. Do we need to wait for 5 minutes for bonding to mature, since it helps with the bonding strength? I think this you have answered the question.
Yes.
5 minutes, 30 minutes.
Yes, you answered it correctly.
5 minutes.
Great. The question answers it. So good job, whoever who asked this.
Thank you so much.
Yes.
Next question. Thank you, Dr. Kathleen. May I know how much time would you allocate for your BRD appointment? That's a good question.
Okay. Yeah, that's a really good question. Very practical. My front desk knows that if it's a build up and an overlay or an onlay appointment, it would be definitely 1.5 to 2 hours. Last time in the beginning, when I just started BRD, they don't know. They're like, okay, why are you taking so long? Or but now they know, because they see my nurses follow me on Instagram. So it's good. It's good that you have an Instagram account and your nurses follow you. So they internalize even when they're at home. They're like, oh, this is what they do. Yeah. So how much time? Yes, I would always allocate 1.5 hours. If for BRD appointment, if it's an indirect, definitely 1.5 to 2. If it's fiddling, I would do 1 hour per restoration. But normally it's 1.5 lah, and I don't really do 1 hour.
I mean, I do agree. I mean, the time for basically for any treatment, especially if you're doing a nice biomimetic treatment as well as putting your aesthetic treatments, you take photo with rubber dam. I think everyone should take the time at least 1 to 1.5 hours, because sometimes your rubber dam doesn't just go in 2 minutes. It takes some time. So
It's true.
yeah. So yeah, I think as well as the person who asked this question, maybe as you practice, you might get to know your estimated time also. Different people, different time, I guess.
Yes, yes. Recently, my nurse and I, she's here also, Jess. We realized that we've been very quick with our rubber dams, and she's like, "Oh, doctor, you need to take video and put it on your Instagram." I'm like, okay, okay. So like, practice makes perfect. Like you would really, I used to take like 10 minutes for a rubber dam, which is crazy. Now, like you can do it within 1 minute. Like it,
Oh, that's true. I do agree. As the more you practice, the more you get used to it. You become faster.
Yeah.
Thank you so much. Hope that answered that question. Next question. Sorry. Do you replace glycerin? Do you place glycerin immediately after IDS before taking impression, or after impression before placing temporary? Thank you.
immediately after IDS. So after IDS resin coat, then if you want to expose your enamel, you can polish, kind of reshape or polish up your bio base, and then glycerin cure immediately. After impression before placing. Yeah. Do it before your impression.
All right. So answer before impression. Thank you so much for that. Will other fibers, right? It's a very good question. GC, Everstick, or cord function the same as Reborn?
Yes and no. Reborn is a multi-weaved polyethylene fiber, so it resists kind of deformation in any way you pull it. You can kind of take it. Other fibers, I'm sorry, I don't know. I know that you can use other fibers as well. It also helps reinforce the hybrid layer, but it's also one thing to note is they are not all as thin as Reborn. The Reborn that I'm using is Reborn THM, so it's 0.18 mm. So that helps because you don't want to build up your your filling too fast and too thick as well. So the rule is keep it to less than 2 mm for the first 5 minutes. That's what David Allman always say. If you can have a tattoo on your arm, tattoo this less than 2 mm the first 5 minutes. So if you're using a very thick fiber, then it might pull away as well. Yeah. Try to use Reborn.
Yeah, we tried to use Reborn first. I mean, GC Everstick also, like they already told their function is basically for certain function, not to use as Reborn function. So I think
like resin bonded bridges maybe.
Yeah, FRC, yes, or perio bridges, perio spleen. You can use Everstick, but for this, I think we better use Reborn.
But if it's the only thing that you have, you can. If it's the only thing. If you need to finish the stock, you can.
To test run first. Then yeah, I do agree with the 2 mm thickness, because even a lot of studies have said, when you light cure, your light cure only cures maximum of 2 mm of thickness of your resin or composite. So try not to go more than 2 mm. I would recommend that as well.
It's true.
All right, next question. Let's see. Next, which brand of bonding agent do you use? Since gold standard bonding agent are rather expensive. Thanks.
I use Optibond FL. It's a gold standard.
From Kerr, right? If I'm mistaken. The company of it.
Yeah, people say it's expensive, but okay, if you think about it, for how long it lasts, it's really not that expensive. It lasts a long time. Like Optibond FL is like 8 ml. It lasts a really long time.
Yeah,
so cost per use, it evens out. It's just like the very first purchase lah. That is like painful, but after that you realize that it lasts a long time.
And especially when you have this purchase, you're going to charge the patient also like that.
Yeah, I mean, you charge for your time, you charge for your expertise, you charge for knowing what you're doing, and your confidence and predictability, repeatability. Yeah,
I do agree with that. All right, next is, do you use the same BRD approach for cases with reversible pulpitis?
Exactly, you do. Because the BRD approach, so you see, like in that case with my patient, the one that I failed and yeah, I didn't use the BRD approach. So my first mistake was already perforating the pulp. And then no BRD dentists use like Dical and Bichapon all over the floor anyway. So if the first time I did with the BRD approach, then I think it would have been different, the results.
So I think one thing that just my 2 cent consent to say, like, like we are so used to, like, okay, pulp exposure, I can put it, close it up, open it back up. But I think this BRD concept is something new that we have to unlearn to learn this new concept. And
It's
I do agree with that.
it's true.
Okay, next, almost similar question, but here they say that what if you accidentally have pulp exposure or pinpoint red dot? How would you approach and manage from here?
Oh, that's a good question, because I mean, now that I measure, I don't really get it as often, but it happens if sometimes in like young patients, the pulpal horns are not within the 5 mm range. So you'll be like, oh, I didn't know that I went so deep, but you didn't. And yeah, so different anatomy has different repercussions. But if I accidentally had a pulp exposure or a pinpoint red dot, I would stop the bleeding. And normally, because you're going so slow, you normally wouldn't it wouldn't be a big problem. Just make sure it stops bleeding. And sometimes blood doesn't ooze out. You can just see that, that red dot. Okay, it's not that blood is oozing out. So I would just continue as usual. If it's a bigger one, what you can do is, liquidem. You can just put liquidem on that pinpoint red dot, cure it, and then etch and bond as usual, so that you don't if you don't want your etchant and your bonding agent, your primer, your adhesive to go kind of infiltrate into the root canal, then put the liquidem there, cure it so that it's like a door, and then you continue doing bonding your entire floor and the walls, and then you remove that liquidem and then you continue.
Okay, that's a very neat trick. I'll try that next time for sure.
No, not try not to have an exposure, but yes, the next time if it happens, yes.
If it happens, yeah, I'm gonna try that. I'm not gonna simply expose. No, I'm not gonna do that unless someone wants to volunteer for that. I don't mind. All right, next question. Hi, Dr. Kathleen. Is there any effect on the bond strength between bio-base to the non-retentive onlay that will be cemented? Any tips on how to maximize the bond strength? Thanks.
Any effect on the bond strength between the bio-base and the... Oh, you mean wait. That will be cemented?
Yeah, I think bio-base and the onlay that going to be cemented, you're going to have onlay, you're going to cement it. So they're asking is there any tips to maximize the bond strength during that?
Oh, okay. How do you maximize the bond strength? So you have your bio base, everything is nice and sealed. Maximize your bond strength. That having a bio base already maximizes your bond strength. So if you have a bio base, you've already IDS and resin coated, you're good. That's really the best way that you can maximize your bond strength. And so all the tips that I shared today, using CDD to make sure that you're maximizing your bond strength in areas that are pink, you would have a kind of loss of slight bond strength. So make sure in areas that can be kind of removed without perforating the pulp, remove them so that you maximize your bond strength. That's number one. IDS and resin coat. Rubber dam, making sure that there's no infiltration of bacteria and saliva and seepage. That's the way to maximize your bond strength. And then you bond with resin adhesive resin cement. You can use anything.
So basically, the basics is the important part where your CDD, your IDS,
exactly.
And that's the most important thing. And yeah, rubber dam is a must for this kind of cases. Please, guys, use rubber dam. It's quite, you guys want to get more into rubber dams. Sean is always there to help anytime. All right. Next is let's see. Dr. Kathleen, do you recommend pre-soak the cavity base with chlorhexidine prior to bonding? Does it affect the bonding strength?
That's a really good question because why if you're using like the gold standard that I said, the Clearfield SE Protect, Clearfield SE Protect has the MDPB monomer, which which kind of like stops the action of MMPs. So matrix metalloproteases, these are, I mean, like people say that they affect bond strength and they reduce bond strength over time. So especially when we are using like a 4th generation total edge, yes, you want to pre-soak the cavity base with chlorhexidine, but it's not like the chlorhexidine mouthwash. Okay, we need to use like the, what's that? The chlorhexidine? Concepcis scrub. Yes, to deactivate the MMPs. And then it doesn't affect the bond strength. If anything, it increases the bond strength. So that's really good. Or one way to deactivate MMPs is also to use, if you don't want to like add another step to your protocol, then you can etch with, I know Bisco has the Uni etch. It has BAC, benzoyl ammonium chloride, BAC in it, which also deactivates MMPs. Yeah, so either or, you can soak the cavity with chlorhexidine, Concepcis scrub, or just simply use the etchant you use. I think it's simpler to change the etchant you use to the one that has
Unless
BAC.
you want to add extra steps. Yeah, I mean, I do recommend you add extra steps and want to get more higher bond strength. So hope that answers the question. Thank you so much. Last 5 more questions, then we're done. After we only 30 questions, there are a lot of questions answered. After you have made your bio base, do you clear the bio base at area on the enamel?
Yeah, you do. But remember what I said just now? It's better to leave some on the enamel rather than accidentally expose some of that thin. So you can, but be very clear on what you're doing. And as a tip, you can leave like imagine the width of your enamel, leave like, you can clean the outer 2/3, but the inner 1/3, just leave it, just in case you like accidentally expose your dentin again.
All right. Which method better when used rebond? Repeat it before rebonding, or just put it dry and then we wet it?
This actually, yes, this is actually a very controversial topic. Because if you know the guy who is like somebody that you must follow on Instagram is Philip Kulemans, and he is one of the researchers for EverX. He actually was in the lab. So he's a PhD biomimetic mastership guy as well. And what he recommends is it always need to be pre-wet before placing it into your cavity. But the almonds, they advise to just place it in and then wet it with adhesive. Either way, as long as it's fully soaked with adhesive, you're okay. Yeah, but I know some people find it hard to wet the rebond, and it's like very flimsy, and like you might drop it, and then that's like some really expensive rebond on the floor. But you want rebond on the floor of your cavity, not rebond on the floor of your clinic. Okay, anyways, but yeah, so either way is fine, but just whatever works for you. If you find it very cumbersome and troublesome to like carry a wet rebond, just place it dry, then like make sure that it's fully wet before you pour it.
So the concept is try to make it fully wet and do not rebond your clinic floor.
Yes.
Any experience on rebond of your clinic floor?
Not on the floor, but like on the napkin. But after that, we like once it's on the napkin, we don't use it.
All right. Yeah. All right. Next question: do we pack rebond on the floor only, or the floor and the wall in case of class 2 cavity? Thank you.
Yeah. Yes, good question also. It's I guess it depends on how deep your floor, and if your wall needs some reinforcement, imagine like you're having a very thin wall, then and if you want to kind of thicken and reinforce and kind of mimic your DEJ on that wall, then you can place it on your wall. It's really up to you. There's no right or wrong with ribbon unless you're, just the thing about ribbon is don't expose it, because it like fibers kind of like imbibe water. So don't let your ribbon be exposed to the oral cavity. That's all I'm going to say. Yes, so on the floor, normally for me it's on the floor, but if I have like a very deep axial cavity, like a very deep axially class 2, I would place it there, like there, and then this is a floor, I would kind of like blanket it.
Okay.
Yeah, depending on which is the deep one. If some floors are shallow but the wall is deep, so place it wherever it's deepest, and you would want to reinforce your hybrid layer.
All right, hope that answers the question. Next question, since ribbon and posterior LX has different indication, does that mean that in big deep cavity, we should put ribbon below and pack the posterior LX before direct restoration, in case patient die with one direct restoration?
I feel like this is this from Ivan? It sounds like him. Yes, correct, exactly. You should put ribbon below and then pack with Everex posterior before building up your cast and all that. Yeah.
Okay,
right.
Thank you for answering that question. You said earlier that you place RC during DWT. Does that mean that you cured the IDS and RC together, or IDS cured then RC cured? Thanks.
You cure your IDS first and then you cure your resin coat, not together. You want your IDS layer to be just adhesive.
One step at a time.
When I said like I place my resin coat while waiting for DWT, while waiting for decoupling with time, I mean, because remember I said that the clock starts the minute you cure your adhesive, meaning the moment you cure your IDS layer, the clock starts for five minutes. Use it, like what you can do to use up that 5 minutes is to place your resin coat, ribbon, things like that.
All right.
Yeah. So you cure them separately.
Hope that answers the question. So we have one last question. Well, actually, we have more, but we stop at 30. Okay. Hi, doctor. How do you do the provisional crown and how to temporary cement it?
I haven't done crowns for many months. I've only been doing non-retentive onlays. I saw Shini asking about Biorim. Let's get into that later, because I think that's very important. How do you provisionalize the crown? I don't do crown, but yeah, I mean, wait, what am I saying? Yeah, I don't do crowns, but if I would provisionalize an onlay, if that's what you're asking, normally I would, build my bio-based IDS resin coat, DME if needed, fibers if needed, and then my final bio-base, I would just place a temporary resin, light cured resin cement. So I'm using Fermit. You can Google it. Yeah, so I just stuff it, lock it underneath the undercuts, and normally in the second visit, it's still there. Like 90% of the case, it's still there. The Fermit will still be there. Yeah, so you don't have the temporary cement like onlays. You can just, I know some people who place like liquidam underneath the height of contours just to lock it in place, because you're not worried that there's going to be bacterial seepage because you've already IDS and resin coat. So the only thing you're worried about is drifting. So mesial drift, like just drifting of the teeth. What you want to do is just like lock the tooth there in the position, so that the time that you get back your onlay from the lab, like you don't have to do so many like adjustments.
I agree with that.
Oh, and then the Biorim. Yes. Can I explain more about the Biorim? I can. Sorry.
No problem. Go ahead.
I can, right? Just like, yeah, I know this is quite an important thing. The Biorim is the 2-3 mm above your CEJ, and you know how when we are preparing crowns, we kind of like, it's just 360 degrees. You're actually cutting off the teeth at the most fracture resistant part of the tooth. So meaning the neck of the teeth, that's the most important. So that's why you will never catch a biomimetic dentist doing crowns, period. Unless it's crown replacements, because we are all about conserving the teeth structure, right? And treating the teeth how God has made it. Like referring our reference is the perfect tooth. So we would never crown it. And when you crown, you actually invade and you destroy your biorim in the process. That's why you see a lot of crown fracture. You see a lot of like catastrophic fractures with crowns. The moment you preserve your biorim, any flexing is still taken up by the biorim. Yeah, so that's why biorim preservation is so important to biomimetic dentists.
I hope they answered the question. Last slide. Apologies, we have reached the end of our Q&A time. All right. So before we go, before we take our group photo, just want to say that if you guys have any questions to ask, you guys can follow Dr. Kathleen Tan in her IG and can ask her there. And we do have a few other dentists who do practice biomimetic, like Dr. Naveen, Dr. Melvin, etc. and all that. We have quite a number of them here also. So you guys can follow them, ask any question to them also. Don't be scared, they won't scold you, they'll teach you very nicely. As you can see, like Dr. Kathleen explained, her brief also is like very detailed already. So thank you again, Dr. Kathleen, for helping, for sharing your knowledge. Big help. Before I would take photo, I would say thank you to our sponsors, restaurant, and also our MD8 Toastmaster Club. So can we get a group photo, please?
Who's taking the photo? Ken, is it?
Yes, Ken, are you taking the photo, Ken?
Sure, no problem. Come.
Okay.
So everyone, please on your video.
Everyone, please on your video.
Yeah, show us your pretty and handsome face. Come on. I can see someone smiling. So nice. All right. Okay. There are 8 pages. So I'm going to take. Yeah, so, because we have almost 300 participants, right?
We left 300.
Oh, yeah.
We have full house. Again, thanks again, Dr. Ken.
Yeah. All right. Come on, look at the camera and hold your smile in 3. Wait. Sorry, I have to close the chat box for a while. All right. Smile in 3, 2, 1. Okay, move to the next one. Smile in 3, 2, 1. Again, 3, 2, 1. One more. 3, 2, 1. One more. 3, 2, 1. And last, 3, 2, and 1. All right. Done.
All right. Thank you so much, everyone, for joining. So
Thank you.
again, before I end this, again, thank you for Dr. Kathleen Tan spending time. Thank you for the participant for all the positive questions and joining. Very big help. Thank you, MD8 Toastmasters and all the club MD8 council members for helping. Thank you, restaurant. So again, we have before I finish, just want to say we have promo from restaurant. All right, I'll share it in my IG as well, and I've a screenshot of a promotion for the CDD also by Dr. Kathleen. Thank you, Dr. Kathleen, for arranging that. Maybe we can do group buying of CDD later. And also we have our next speaker will be on 19th August. So normally I know every month I do two sessions, but next month I'm only doing 1 session. All right. And also, yeah, I'll be starting up my, as you guys know, I'm starting up my MFDS Part 1 preparatory course as well. You guys can follow my IG. So it'll be online this time as well, no physical. So yeah, that's the only update I have. Again, thank you everyone. Thank you everyone for joining. Thank you again, Dr. Kathleen.
Thanks,
have a nice
for having
day.
me.
And before we finish, anyone knows the update for the badminton card?
Yeah.
Please. Anyone?
Oh.
We lost.
We lost.
Joshua.
Everyone, you can unmute yourself actually right now.
Anyone want to like say hi or get to know Dr. Kathleen or MDA Toastmaster people? You guys can just unmute, say hi, and
Thanks, thanks, Joshua.
Joshua gave a very nice one. 19, 21, 19, 21, 5 last two set. That's sad, but it's okay. We're still up to third place, right? At least, right? Correct, right? Yeah, so let's hope he wins and at least menang tempat ketiga. Semi-finals, right?
Hi, Kai. Your parents say hi.
Oh, it was quarterfinal.
Oh my God.
Oh, I can see.
Those are my parents. Hi,
Oh,
Mom. Hi, Dad.
Hi, doctors.
Congratulations. You did well.
Oh, thanks, Mom.
That's
Well, thanks,
the
Niraj.
Tan's family. Wow, very
That's
good.
my sister. Yep.
Thank you so much for support for Dr. Kathleen family support, big support. Khairuddin, yes, he said it's eye opening session. Thank you very much. Right, anyone? We are done. If anyone want to leave, can leave. No worries. If anyone want to say hi, want to get to know Dr. Kathleen, you guys can. No problem. All right, I can see someone. I can see a joke. Skipping master also is there. Yes, Nazrin is the skipping. Must always upload his Instagram with skippings. 100 days of sweatings. Good, good.
Melvin is here. Hi, Melvin.
Hi, Melvin. Dr. Melvin, can you like say hi?
Hi.
Yourself? Yeah. Thanks for joining. Everyone, Dr. Melvin is saying you guys can follow him. Also, he also does.
Melvin's amazing.
His work is awesome. Please do check his work. Really good work he does. All right, you guys can follow Dr. Yeah, that's Dr. Melvin. Yeah, there it is. So you guys
Good to
can.
finally meet you. We've never met,
Yes.
but
Yeah, Dr. Melvin, I've not seen you or
I'm
you know.
I'm not dressed up, man.
It's okay.
where's the baby? That's what we want to see.
She's sleeping. I need to go somewhere.
Dr. Melvin is overworking.
No, she slept already.
Oh,
yeah.
okay.
Fast asleep.
I always tell Melvin that the only reason why I'm following him is because of his baby. No, I'm kidding. He's amazing.
So you guys can
not
follow.
only you actually. There's a lot of people follow me actually. It's just to see my daughter.
That's so sad.
All right, and thank you so much. Anyone else here want to say hi from other countries? You know, just drop by.
Great presentation. Okay.
Thank you, Melvin.
Sifu Melvin said good.
Melvin knows.
Good.
Yeah, Melvin knows most of the things anyway.
No lah. I learned a lot.
Thank you.
No profile. So thank you, Dr. Zion. Anyone else want to say hi before we close? Anyone want to ask about Toastmasters? You guys can introduce yourself to the Toastmaster Club. Say, hey, I want to join. How to join? You know, I want to join.
Can I ask a question?
Yeah.
I mean, like, since everyone's still here, do you take a routine PA X-rays before you decided you want to either fill the teeth or
Yeah.
you know this teeth is going for root canal treatment? Because
Yeah.
I mean, like doing a biomimedic restorative approach, basically you need to make sure that the tooth is not already involved or have any
Right.
PA lesions.
Exactly.
Right? So you do take a routine X-rays before you start?
Always.
Okay.
Unless like you start already, then you think like, oh, I'm saving it, but
Yeah.
it's actually non-vital.
Yeah, what
yeah,
happened?
so-
I mean, like, do you encounter that?
I mean, so far no, because I always take PA X-ray and co-test first. But never say never, it might happen to me one day. When you think like it's simple and it's vital, it's okay, let's just repair this part, but it's actually not. No, it can happen.
I did a few cases of it's like, you know, you spend like an hour plus, you want to feel that everything's like, oh no, oh shit.
I think
you find out after your post-op X-ray. I just wasted 2 hours.
Yes.
It's okay, at least your hybrid layer is strong. That's all that matters.
But I'm not sure whether Another thing is that you mentioned regarding pinpoint power exposure, right? And then you said that you can like you can use liquid dam to close that, and then after that you etch, you bond,
I
then
agree.
you
Actually,
remove.
the liquid dam is mostly to protect it while you air abrade. Because a lot of people, like especially in the
Yeah.
biomimetic circle, when you see like a little pulp exposure, once you air abrade, the entire thing becomes like open. Yeah, so
Yeah.
that liquid dam is mostly to protect it from air abrasion lah, more than anything.
So after you bond, you resin coat, then you remove.
Yes. Yes. Actually,
And
for me
what
personally, I don't want to,
Yeah.
I know like, I don't want to teach you something wrong, but what I do, because I believe in the bond, right? So if there's a pinpoint part exposure, which is like, it's still covered by like tertiary dentin or like some amount of dentin, I don't even liquid dam or anything. I just like straight away go into etch, like prime and bond.
How do you determine when exactly that you will perform a root canal, or you were still
Oh.
doing the
I
how
always
big is
right. You mean like when you accidentally expose, right?
Yes.
Like when that's yeah.
Like the
If
case that you did in December, just now you mentioned.
yes,
You placed diatel and everything, right? Yeah.
yeah, that one I was like super not woke lah. So sorry, like don't learn from that case, but learn from the failure. But that one, I don't know, like I guess I should have done root canal. I mean, just because you have a pulp exposure, you wouldn't, I don't think anyone would like, just because you have a pulp exposure, you would proceed to endo. There's always some sort of reparability left in the tooth. And one thing is just continue doing what you're doing, because even if somehow the patient comes back with symptoms and like pain and then like irreversible pulpitis, at least you've done your like, kind of what they call it now, IPDS, immediate pre-endo dentin sealing. Yeah, so whatever it is, just don't proceed into endo yet. Just do your IDS and like build it up first.
No, wouldn't it will, if, let's say if you do that, I mean, like some patients are not really, how to say, they don't really understand, the effort or the things that we're trying to do for them. If you already filled up that kind of tooth, and then if the patient come back, then it's okay. I mean, like if they believe in you and come back with pain and everything, then you proceed with canal treatments. Some patients, they don't.
They leave,
They
right?
won't come back.
They go to
leave,
another dentist and then they say,
and then they correct.
Yeah.
So for a lot of those, this is very common, in Malaysia. I'm not sure about other countries, but in Malaysia it's really, really common. It will happen.
Yeah.
So that's why it's for cases like this. How do you decide? I mean, like, of course, if your clinics, I mean, like, if your practice is already established, then definitely patients will, or if you already, well known, then patient will definitely come back.
No lah, in my case, they'll be like, okay lah, 我买看耶，早啊，我看爸爸。
I mean, that's the problem when you work in a family dentist and you're so used to your father and you're so used to your father.
It's like, but
It's true. We
It's
agree.
true,
we
your
agree.
sister is supporting.
yeah, but I believe like communication is the biggest thing. So like with my patients, I always take them through every step, even if like if they come complaining to me, then that's good because they are aware of it, right? They like they embody that the fact that they are in pain and they need help, they need intervention from a dentist. But if it's something like you see like a hugely like structurally compromised tooth and you go and dig it out, and then if anything happens, then that's your fault. But in any case, like I think in every one of our lives, like communication with our patients are very important. So I would like always say, I guess, it's just communication and like setting them up for like, if anything were to happen, like we can still do a root canal. But let's hope for the best. And you see, like that's why I always take pictures. It's not really for me. Yes, it's also for me to like assess and everything. But right after I finish a procedure, after I take out the rubber dam and everything, patient's done, I go through the photos, every single step. Where I place the ribbon, I show the patient. And so like most of my patients are very educated about like what we're doing, like about adhesive dentistry, because of the time that I kind of take to, like they've already invested so much time. So they know that also like there's a 50-50, okay. But it's like, you see, look at all the steps we're already putting into making sure that that doesn't happen. In case it happens, I mean, like, we are humans, and your tooth is your tooth. I don't know what you're doing with it, but in case that happens, at least we can root canal it in the future. But just go home knowing that your tooth is properly bonded and totally sealed.
I see.
Mm.
Thank you for your
Questions
answer.
here for Dr. Kathleen. First thing, someone is asking, Dr. Kathleen, earlier you mentioned about Instagram, Dr. Philip something. What is full name? Phillips?
Oh, Patrick Kalalang, is it?
No,
It-
Philip.
oh.
Philip.
Philip. Wait. Oh,
Researcher
Philip
for
Kulaman.
advanced.
Okay, I'm going to type it.
Yeah.
Let me
And
type.
then from Dinesh, she said, Dr. Kat, I expected you to end the session by saying, get bonded, stay bonded.
Yes, I actually forgot to do that, but I'm like, okay lah, I don't want to like.
And I'm also
like-
quite shocked. Sean also didn't say, like, because he's with the family bond stronger now joke.
Oh,
One bond is stronger, stronger family. That's a make it seem that. Okay, Dr. Kate, what about placing biodentine over those pulp exposure? From Sindhu, hi Sindhu, you got in. She wanted to get in. This time was full. Oh my god!
yeah, no,
Thanks Sindhu for getting in.
Personally, I don't have any experience with biodentine. But if you have it in your clinic, I know some people who still use it, especially over pulp exposures. I think you can use it lah, if you have it.
Hi, Kate. It's me.
So
Hello.
guys, so
Good
everyone,
to hear
Hi,
you.
Dinesh. Hi, Melvin.
everyone, guys,
Hi,
if you
Kate.
guys want to learn more on aesthetic dentistry, please
Yes,
get in touch with Sindhu. Dr. Sindhu has an amazing practice in Plaza Arcadia in Desa Park City, and she does amazing
Huge
work.
practice.
Yes, and do get in touch with her, and she does amazing work. And her
Thanks,
Thai
guys.
tea-
A bit too
Yes.
much lah. Not that great lah.
she's just
Actually, I think
being humble. Sorry, guys.
Dr. Sindhu also does study on amalgam, removal amalgam fillings, if I'm not mistaken, the study on amalgam, right, Dr. Sindhu?
No, so right now I'm actually writing my thesis for my master's, which is basically on restoring teeth that have been very heavily restored with amalgam. And in those cases, you kind of find a lot of cracks and all that. So it's very in tune with what Kate was kind of presenting on today. So yeah, with this whole aspect of biodentine, it's something that I actually use a lot in my practice. And because of Kate, actually, I've actually started going into this whole IDS and RC and everything.
I was talking about you, girl.
Yes, I heard. So yeah, it's been pretty interesting for me so far, personally, implementing this in my practice. And
This works.
it works. I would say, especially where dentine sensitivity is concerned, post-operative dentine sensitivity, that is something that I have pretty much been able to eliminate from my practice by implementing this entire concept. Now, where Melvin brought up the point about pulp exposures and potential RCTs and things like that, I find this very, very important because as much as possible, my personal view is that we have to keep the tooth vital.
Correct.
The moment the tooth becomes non-vital, you're setting it on a course to potential failure at some point or the other.
Their cycle, yeah.
You know, the tooth's life cycle is essentially shortened. So my personal view is whenever I'm going in to restore any of these teeth, whether they may be whether it may be an onlay, whether it may be a direct filling or anything, I would first pre-op x-ray and an EPT test. So the moment the EPT goes anywhere beyond like 18, 19 onwards, I know that the pulp is pretty much 50-50. So that's where I start telling the patient, hey, look, there is a high chance that this tooth might require root canal. But if the tooth responds vital, then I know that I don't really have much of a problem there.
Correct.
So when I go in, and if I happen to have a pulp exposure, or if I even see the pulp kind of shining through, this may be a little bit at odds with what you might practice, but if I can even see the pulp kind of shining through, I do apply a little bit of biodentine on the floor in that area. And then I go ahead with my IDS and sealing the dentine and all that. And so far, it's worked out pretty well for me. I don't find patients having issues. And biodentine has been something that I've been using since I started my practice. So that's almost 3 years now. And touch wood, so far, I've not had patients who needed to come back for a root canal, other than those early days when I never used my EPT to actually check. So yeah, it works. So
I would see how it works.
Keep the tooth vital.
Yes,
wherever
but
you can.
also I think what you're doing is placing it like right where the pinpoint is. Like
Yes,
just
correct.
like that.
Correct.
It's minimal, like less is more. Just like
Exactly.
one that
You're
little
not
dot.
packing up the entire area with the biodentine or anything.
Correct. So like I just want to tell everyone, don't do what I did with my failure case. Like that's not what Sindhu is doing. She's just placing it right where the pinpoint is, so that you're still maximizing your bond strength from the rest of the floor and the walls. Yeah, you're not kind of shooting yourself on the foot. That's what I'm saying. Yeah.
Hey, thanks for sharing. Maybe next time I should invite Sindhu to give a talk on,
Mm.
restoring
Yes.
restoring extensive, feelings. Since it's your thesis and, you've been doing that, a lot of research on that. It'll be nice, it's a very nice concept, about that. Also, Dr. Janani said, thanks, Dr. Kate, for simplifying ideas. I've been cracking my head about it.
Jen is my classmate in uni. So
okay.
hi, Jen.
That's good. Even Dr. Wong Hong Zhang, or we call it Professor, he agrees that Sindhu should give a talk on the extensive restoration, which I do agree. It's a very interesting topic, actually, how to remove the amalgam and, how it's something quite important because our generation, we're going to see a lot of, even in my practice, I see a lot of people coming up with, patients are so used to it that they're coming like, hey, can you remove my amalgam? Can you put composites? And they're quite concerned. They're not say concerned. They're quite well educated to know. Like, I have one patient literally coming like, "Hey, I follow this Dr. Griya." I'm like, "What?" Like, "Yeah, I follow Dr. Griya. Can I do work like him exactly?" I'm like, "That is Sifu level. I try my best. I don't think I can do that." But yeah, people do follow this kind of people in social.
Dangerous when
Yeah.
patients follow this.
Yeah. So the benchmark of dental treatment is getting higher. Like if you go to Malacca, you have Dr. Yazid. Everyone is going to Dr. Yazid, and people are like, "Can you do like Dr. Yazid does his veneers?" So it's getting like benchmark is getting higher as well. So yeah, it's good to equip with all this knowledge. I mean, like obviously learning this is like introduction. That's why we do this kind of webinar. That's why I want to do this kind of introduction, what's happening. But someone have to take the initiative to get deeper into it.
Hi, Caitlin, I have a question.
Yes.
Okay. Hi, Leandre.
Leandre.
So I also want to ask about the red pinpoints, all the stuff lah. Because I've recently experienced a lot of deep fillings and deep cavities. So when you reach the pinpoint part, do you actually etch the whole thing? The etch also touches the pinpoint area.
Okay. So we would etch the enamel first and then etch the dentine. This thing is like, it's like cracks. It's so hard to put your finger on it, and it's hard to compare different pinpoint lesions because every pinpoint lesion looks different. The pinpoint lesion I have in my head might not be what
It's
you
not
have.
it's not the bleeding kind of pinpoint. It's just that very translucent kind of.
Right. Yeah, I would still etch it. And
then the bond goes over it and the flowable goes over it as well.
Yes. Firstly prime, and then adhesive, then your flowable.
Then the other question was because if they have those old composites that have secondary caries,
Hmm.
and they are so deep until the floor of the cavity,
Hmm.
removing those composites are a pain, and you have no idea how, when the water splashes, you don't know how deep to go, and you're so afraid that the further you cut away the old composites, you expose the.
I think it helps, Leandra, it helps to take a bite wing or a PA before you start. So that it's kind of having like a roadmap before you start your journey. Yeah, that's what my dad always say. But